Assalamu alaikum. I'm Dr. Momina Malik, and today we'll be continuing the topic of age-related macular degeneration. In the previous presentation, we have already covered dry AMD, and today our focus will be on wet or exudative or neovascular AMD. By the end of this presentation, the audience will be able to describe exudative AMD, pathogenesis and clinical picture, the investigations ordered, and the treatment planned of wet AMD. So, who can describe this picture? Anyone?
Hyperreflective retinal pigment epithelium detached from the Bruch's membrane, Bruch's membrane. OCT macula of right eye.
Yes, so this is the OCT macula of the right eye, indicating if we start from one side, incomplete PVD, the foveal contour is normal, and there are multiple hyperreflective elevations of the pigment epithelium with variable internal reflectivity underneath, indicating PEDs as well. So this is a picture of a patient with dry AMD. So what is the hallmark of dry AMD if we have a quick recall? Drusen, very good. And what are the risk factors? Yes, flash mnemonic with the female family history, light iris color, age, smoking, hyperopia, hypercholesterolemia. Same is the case for the wet AMD as well. And what is the most important or significant risk factor? Age. And what is the most important modifiable risk factor? Smoking. Okay. So moving on to the wet AMD, what is the clinical hallmark of wet AMD? It is the presence of subretinal fluid. Okay. So here we have a fundus photograph of a patient having dry AMD. We can see the drusen, the pigment clumping, and the geographical atrophy. And in wet AMD, we can see that there is elevation of the neurosensory retina with subretinal hemorrhage present. So before moving on, we'll have a quick review of the layers of the retina. So basically, important for today's topic are these layers: the photoreceptor layer, the retinal pigment epithelium, the Bruch's membrane, and the choriocapillaris. So as you can see that the Bruch's membrane, it is present between the RPE and the choriocapillaris, and any damage or breach or disruption of the Bruch's membrane will lead to a continuity between the RPE and the choriocapillaris. The Bruch's membrane, it is further divided into 5 layers. The basement membrane for the RPE, the outer collagenous layer, the middle elastin layer, the inner collagenous layer, and the basement membrane for the choriocapillaris. So basically, any damage to the Bruch's membrane will lead to a continuity between the choriocapillaris and the RPE. That is important. So how does a dry AMD convert into a wet AMD? So dry AMD, as we've discussed, the hallmark is the presence of drusen. When drusen are present, there is associated thickening of the Bruch's membrane, and that will ultimately lead to the damage of the Bruch's membrane. Now, when the damage occurs, a pro-angiogenic environment is created, and there is release of multiple growth factors, the most important of which is the vascular endothelial growth factors. This will promote the neovascularization and increase permeability. As the new vessels, they are leaky, there will be accumulation of subretinal fluid and ultimately development of choroidal neovascularization. So this is the normal macula of the retina. You can see the RPE, the Bruch's membrane, and the choriocapillaris. Here, this is the picture of dry AMD, and there are drusens present, and RPE cell atrophy is occurring, and there's associated Bruch's membrane thickening. And when damage to the Bruch's membrane occurs, as you can see in this picture, then the connection between the RPE and choriocapillaris is established. There is new vessel proliferation, and there will be accumulation of intraretinal fluid and hemorrhages and subretinal hemorrhages as well. And this will be a picture of exudative AMD. So choroidal neovascularization consists of blood vessel complex that extends through the Bruch's membrane from the choriocapillaris and occurs when the Bruch's membrane and RPE function has been compromised. So we can anatomically classify CNV according to the level of origin into type 1, 2, and 3. Type 1 is new vessels originating from the choriocapillaris and growing to the sub-RPE space. Type 2 originates between the RPE and the neurosensory retina. So these are subretinal. And type 3 develops from the deep capillary plexus of the retina and they grow downwards towards the RPE. So the supply of the retina up till the inner nuclear layer, it is by the choriocapillaris, by the choroid, and above that it is by the retinal vasculature. So basically type 3, it is not originating in the choroid, so it is also known as macular neovascularization, while type 1 and 2, they are originating from the choroid, and based on the location they are differentiated. So how will a patient present to us? Hmm. So there can be acute or subacute painless blurring of the vision, metamorphopsia, and paracentral scotoma. What will be the signs? The CNV, it is seen as a gray-green lesion, and there will be medium to large drusen's present, and associated PED and hemorrhage can be present. In the evolved or the treated lesion, disciform scarring can occur. So here you can see the gray and green appearance of the CNV, the medium and large drusen. They are present over here. This is a hemorrhage, associated hemorrhage that has occurred, and this is the fundus photograph of a late stage of the disease indicating disciform scarring. So what investigations will be ordered? So primarily the investigation for choice now is the OCT, optic coherence tomography, and fundus angiography can be done, and indocyanine green angiography can also be done. Why is OCT preferred? As this is a non-invasive investigation and it is critical in the diagnosis and also monitoring the response to therapy of CNV. So what will we see on OCT? What will be the findings? There is basically elevation and presence of subretinal fluid, and based on the location of the presence, we can divide it again into type 1 and type 2. So type 1, the elevation and the subretinal fluid, it is present above the Brooks membrane and below the RPE, as indicated over here. And in type 2, it is between the neurosensory retina and but above the retinal pigment epithelium. And here you can see there is associated intraretinal fluid as well. So fundus angiography, it is rarely done now, but the indications are the diagnosis of CNV prior to the start of the anti-VEGF therapy, or as an adjunct to diagnosis of alternate forms of the neovascular AMD, and for localizing for extrafoveal photocoagulation or guidance for the photodynamic therapy. So similarly, according to the fluorescence pattern, we have divided it into type 1, type 2, and type 3. Type 1 is also known as occult CNV, and it is described when the limits cannot be fully described on fundus angiography. It is present above the Brooks membrane and below the RPE. So here you can see that there is a diffuse hyperfluorescence present, and the exact limit, it cannot be defined. So this is a type of occult CNV, and this is most commonly seen in age-related macular degeneration. Where type 2, which is known as the classic CNV, there is a well-defined lacy pattern, and there is progressive leaking into the subretinal space over 1 to 2 minutes, and the late staining of the fibrous tissue is also present. So if we look at this picture, this is the fundus photograph, which here the gray-green area is being shown associated with a small hemorrhage. So on fundus angiography, you can see that a hyperfluorescence with a well-defined lacy pattern is seen, and the hemorrhage is indicated by a hypofluorescent area. And progressively, the hyperfluorescence, it is increasing and is still well-defined, and this shows the late venous phase in which there is more intense hyperfluorescence present. And then we have the type 3, which is known as minimally classes, and it is a combination of the occult and the classic features, with the classic features being more than 50% of the total lesion. This is the OCT showing both the features. This is the sub-RPE CNV, and this is the subretinal, between the RPE and the neurosensory retina elevation. Then indocyanine green angiography, it can also be done. It provides a better visualization of the choroidal vasculature, and in this we can see a focal hyperfluorescent hotspot or a plaque on the site of the lesion. Here you can see this is the lesion, and on indocyanine green, this is a focal hyperfluorescent spot. So what is the treatment? Initially, laser photocoagulation and photodynamic therapy was being done. Laser photocoagulation was basically for the peripheral regions which were not involving the macula in order to avoid damage to it. And photodynamic therapy slowed down the progression of the disease, but there were no significant improvements seen in the visual outcomes. So then anti-angiogenic therapies were proposed, and currently they are the treatment of choice being done. Why are they proposed? As we discussed in the pathophysiology, vascular endothelial growth factor has a major role in the pathogenesis. So basically, we are combating this with the anti-angiogenic therapy. So we'll have a quick review of the vascular endothelial growth factor. It is a glycoprotein that has heparin binding growth factor specificity for vascular endothelial cell. It induces vascular permeability, angiogenesis, and it also acts as a vasodilator. There are many isoforms available from A to F, and the significant one for I and specifically for age-related macular degeneration is vascular endothelial growth factor A 165. So many drugs have anti-angiogenic function, and for that, first of all, we'll discuss the ranibizumab. It is a recombinant, humanized, affinity matured monoclonal antibody fragment. And the brand name, it is Lucentis or Petisra, and it targets the VEGF receptor 2 in the body. So basically, when this was proposed, a number of trials have been held comparing the efficacy, whether it is effective in this treatment, and comparing it with all the photodynamic therapy and the laser photocoagulation as well, that which one is more effective. So we have the Marina trial, which is minimally classic occult trial of anti-VEGF antibody, ranibizumab, in the treatment of neovascular AMD. One group of the patient was treated with ranibizumab, and the other was given a placebo drug. And the conclusion was that ranibizumab is more likely to prevent visual loss than placebo in patients with neovascular AMD, regardless of the gender, age, lesion size, or the type. And the improvements on OCT were also seen with the drug. Then another trial was conducted, which is the Anchor trial, anti-VEGF antibody ranibizumab for the treatment of predominantly classic choroidal neovascularization in AMD, and here it was compared with the photodynamic therapy. Now the conclusion was that it is more effective than photodynamic therapy with respect to visual acuity. The both slowed down the progression at a comparable rate, but with ranibizumab there were better visual outcomes, and 1/3 of the patient improved by 15 letters. So then other studies were held comparing the dosing schedule, injection monthly versus injection ranibizumab monthly for 3 months and then 3 monthly for 1 year. So according to this, there were better outcomes with a dose of monthly injection of ranibizumab, and this was concluded by the peer study. And according to this, if 3 monthly injections were given, the visual acuity was seen to deteriorate at an interval of 1 year. So then Pronto study was conducted, which is prospective OCT imaging of patients with neovascular AMD treated with intraocular ranibizumab, and it was comparing monthly injections compared with the OCT guided retreatment. And according to this, the conclusion was that OCT guided retreatment strategy had similar visual outcomes, but with a much fewer injections. So then another drug which was studied was bevacizumab, and the brand name is Avastin, and it is commonly used. Recombinant humanized monoclonal antibody. This is not a fragment. This is a complete antibody, and this was basically this drug. It was discovered even before ranibizumab, but it was thought that it is a larger molecule and it will not cross the internal limiting membrane, so it was not used prior to this. But when trials were conducted, the CAT trial, which was comparison of the age-related macular degeneration treatment, it was comparing the outcomes of ranibizumab with bevacizumab. It was seen that there was no significant difference in the outcome of the two. Both had same effectivity. Then we have another drug, which is aflibercept. The brand name is Eylea. It is a recombinant fusion protein, and basically it acts as a decoy receptors and traps the VEGF A, B, and the placental growth factors and inhibits their activity. So view 1 and 2 study was done, which was comparing aflibercept given bi-monthly to ranibizumab, which was given monthly, and the conclusion was that both had same effectiveness. Combination therapies were also studies, and it was shown that the combination of photodynamic therapy with anti-VEGF was not superior to anti-VEGF which was given alone. Laser photocoagulation was rarely used and was suitable for classic small foveal membranes well away from the macular center. And the patients who already have undergone anti-VEGF therapy, despite the success rate, a significant number of patients, they can progress to decreased visual acuity and they may benefit from low vision aids. Thank you.
Please, elaborate